All right, we're getting close to the end of this vascular lecture. So now let's get into a couple smaller topics. First, varicose veins, and then there'll be a different, real quick, short over phlebitis. So varicose veins are another venous problem. So when we think of venous problems, we think of, remember, we like elevation, compression, and movement. So always kind of keep that in your head. And we're thinking of a flow back to the heart problem. What's going on with varicose veins? This is not as much a life or death problem. It's more of a cosmetic issue, but it definitely can cause problems. So we do learn about it for that reason. It's also very, very common. Is what's going on here is there's dilated and very like tortuous or very like thick and like tortuous, think twisty, superficial veins, especially usually most common in the legs. You can also have varicose vein like structures in places like your esophagus, like esophageal varices, in your rectal area, like hemorrhoids, and in your perineal area as well. With what's going on here is that effectively there's just like there's usually a pressure issue. There's too much pressure going on in the legs, and it leads to um, a what do you call it, this torturous quality to it. Now, again, this usually doesn't cause too much of a problem, except in the fact that it can lead to blood more likely to pool in one area. And because blood is more likely to pool, they can be more at risk for blood clots, which we just went over. Also, it can be uncomfortable and cause symptoms. And then the big thing is that it just kind of creates this really unattractive appearance, which a lot of people, it can affect their self-image. So a lot of people want to get rid of them. Some of them we don't know why they happen. They're just more common in women, but there also are some that are a result of trauma, injury, and previous blood clot. Even if we don't know why someone gets one, a lot of times there's risk factors involved, just like everything with cardiovascular. I've kind of highlighted some of the big ones. The things out of our control that we can't really change is our family history. It has this in it, being a female gender, regardless of what gender we identify as. In our genetics, females as a whole are at higher risk for varicose veins. Some of it might be our body shapes, things like that too. Hispanic ethnicity, and then as you get older. Modifiable risk factors are going to be things like tobacco use. Tobacco use really messes with the veins. Obesity is a big thing. Extra pressure on the legs creates extra pressure in the vessels, or pretty much think of it like if there's more pressure here and the body's trying to put blood up to the heart, it's going to be, there's more resistance. And so it can kind of create this bulging in the veins. Multiparity, or having multiple babies. I made a joke in class about, I have a varicose vein in my one leg, and I've had it since I had my son. And so I called it, Dylan, after my son's name. And, but yeah, it seems, what do you call it? It seems it's pretty common in childbirth and things like that. So, but the more children that you have, the more likely you are to have more of them. Because a lot of it's the straining and stuff in childbirth, or the extra weight and, things that we usually put on, or even if we don't put on extra weight, we're carrying a child, there's extra abdominal girth so it can create extra pressure to push that blood back up. Anyway, and then also people that sit for long periods of time or stand for long periods of time are going to be more at risk for varicose veins. So just thinking about people that, especially we want to think about nursing. So, a lot, there's a lot more women in nursing. A lot of nursing leads to unhealthy habits, which can lead to obesity. And then, a lot of us, since we're females, may end up having children, and a lot of us become nurses. So this is why sometimes you're sitting there and you're like, dang, why do I feel seen? Like, this is just talking about me constantly. So needless to say, this is very common, especially among women, in their 20s and 30s and going up, because of the risk factors. So what does a patient complain about? And so a patient may complain of pain or discomfort. They might describe it. Remember, kind of going back to the ulcers, you want to think about how people feel, like how venous things appear. And remember, with arterial problems, we have that sharp pain, whereas with venous problems, we're going to have more of a dull, achy, heavy pain. Patient may say they have pressure in their limbs, or they might even have kind of like restless leg syndrome or tired legs. And then my priority assessments really are just going to be around pain. And then I'm going to be assessing, of course, for complications, making sure they're not experiencing a blood clot. Overall, we usually conservatively treat this. So we're going to just do things like all of the stuff that helps with venous. So rest, elevating those legs, getting compression there, whether it be through SEDs, TED hose, etc. The leg strengthening, the foot pumps, weight loss helps because less resistance. Remember, there's no lack of oxygen or flow issue when it comes to getting to the feet. So it's just about doing all the stuff to get the blood, the valve. It's one of those valve issues. I had a really good thing. Wasn't it like this? Something like that. Like there's a valve issue, where those valves aren't, working well, or that the body needs more support to get the blood back up to the heart. It has too much resistance for whatever reason. Mainly, I'm just supporting them and trying to improve their symptoms. We can do cosmetic procedures. Just know that these cosmetic procedures do not fix the underlying problem, but they can make it look better. So there's like sclerotherapy, laser therapy, with ablation where they literally like burn away the vessels. And then a phlebectomy where they go in and they literally like suck out the blood vessels, they take out, because then you'll grow more and stuff like that. So they can literally take out the tortuous blood vessel, or the veins, excuse me. As the nurse, as a whole, I'm mostly just helping to support and help this patient when it comes to a lot of the stuff we kind of already talked about: elevation, rest, compression. When I say rest, because I know that maybe counteracts, because I'm like, oh, get moving, but rest. But what I mean is that if they're having pain, sometimes rest and elevation can help. And especially if they're having swelling, other stuff, compression. And then we definitely want them regularly moving to prevent clots. I'm going to teach them to try to modify their like risk factors and things like that. So we want them to avoid, sitting and standing for long periods of time, change positions. A good walking program helps. And we also want them to avoid things that are going to constrict their waist. So again, kind of get back to that analogy I gave before of a garden hose that has like some rope tied tight around it that's making it, cinching it in. Same thing. If I had, very bad varicose veins and I'm wearing a tight waistband, it's just going to make it even harder, more resistance for my the blood vessels in my legs to overcome to get blood back to my heart. And then managing risk factors like weight loss, and if they can change jobs or modify their job. And even sometimes it's not about changing jobs, but it's making the job workable. So this to me is just like, I teach a 4-hour class. So sometimes I make sure like on my breaks that I sit down for a period of time. So I'm not standing for the full 4 hours. Trying to vary my position as goes, which is why, like, if you see me moving around a lot in these videos, a lot of times I'm trying to distribute my pressure in different ways. All right, that's the last thing for that. We're going to do that in a separate video. So phlebitis will be next. I hope you learned everything you want to know about varicose veins. See you for the next one.